So this video will be going over electrocardiograms, and this video will be very helpful for people who are learning ECGs for the first time. And we're going to take this step by step. So we're going to go over three things overall, starting with what the heck is an ECG even doing, right? And then that will feed into looking at each of the ECG leads. And then we'll finish off at the end with kind of looking over what a normal ECG looks like. And I think that this will be a really good basis to understand why ECGs deviate from the normal in the way that they do when there's something that's wrong. So what we're going to go over is, what is an ECG doing? And to understand this, we're going to actually go over an example. So imagine you have this tube here. It's like a tunnel of sorts. And in this tunnel, you have a positive charge. And what's special about this tunnel is that it has a sensor right at the very end. This is going to be my sensor. I don't know if you have a little wire or something. It's a sensor right at the very end here. And what this sensor is able to do is it's able to tell whether a positive charge is moving toward it or away from it. So naturally, if this particle were to move all the way here and stop right over here, right, this charge, then what this sensor would see is that at the beginning it was still, and then it moved toward it, and then stopped. So if you take another example, a similar example, where you have another tube here, you have another positive charge, same as last time, except the sensor is on this side, on the other side. And if the particle or the charge were to move all the way to the other side, same as last time, the same movement, and stop, then what this sensor would see is the particle had been still, then moved away from it, then stopped. So next, the next example I want to show is if you were to have a tunnel, the same thing again, positive charge here again, and you have a sensor right in the middle this time. If the charge moves again all the way to the other side, like this, and stops at the end here, then what would the sensor see? It would see the charge moving toward it first, and then it would move away from it, right? So what the sensor would see is, hey, it was still at first, then moves toward it, then away from it, and then now it stops. Now, some of you may notice that basically if you were to take this example here, right, and move it over to here, you'd notice that this example with the sensor in the middle is the same as combining the first two examples together, right? You have the sensor in the middle, a charge moving all the way from the left all the way to the right. So it makes sense that if you were to add these things together sequentially, it would be, hey, it goes towards it and away from it and then stops, right? It's the same exact thing. So that's concept number one. So there are two important caveats to this. Caveat number one is that this sensor is only able to detect things moving toward it or away from it in one dimension, or one direction. What that means is we had, in this example above, we had the convenience of this tube and sensor being along the axis, or this charge is moving along the axis of the tube and the sensor. But if you were to have a situation where, say, you had a charge moving in a diagonal direction like this, you can't fully capture what this charge is doing with a tube that's going this way with a sensor, right? And what you do here in this scenario is, if you kind of go back into your physics days, if you remember, if you have like a larger charge moving in a direct diagonal direction, you can split that up into two smaller charges with its horizontal and vertical components. We won't go over any of the math for that, but just the general concept. But you can describe the movement of this charge by breaking down into its horizontal and vertical components. Similarly, if you were to have a charge that's moving diagonally, not exactly along the axis of one of the tubes, if we were to have another tube that is going vertically, and another sensor, then the vertical sensor will be able to capture the vertical component of this charge's movement as it's moving down. So for this sensor, it'll look like a smaller charge kind of moving down this way. And for this tube and this sensor, the large charge moving that direction will look like this small charge moving along the axis of that tube. And of course, the most convenient way to record this is if you were to have say a diagonal tube like this with a sensor. It can capture the movement of the charge without having to do any other fancy math or interpretation. But what I want you to know is that, for example, if you were to, this one may look kind of like this. This one also look like a smaller charge like this. Whereas this one, it'll look like a larger charge going right along it, so it's going to look kind of like that. It's even larger. So that's caveat number one. So caveat number two is that any given tube or sensor is only able to represent the net movement of all charges moving in that specific tube. So what that means, so it only shows net charge movement. So what that means is if you have one charge moving through, there's no problem. You only need to characterize one charge, right? But if you were to, for example, have tube here, right? Same thing. Except let's put the sensor over here. And you have a large charge over here moving that way, and a very small charge, positive charge, also moving from the opposite side towards the sensor, right? If this charge were not in the picture, then this charge's movement is going to look just like how we went over it before, right? It's moving away from the sensor. So what this charge will look like is look like it's going away. If this charge were not in the picture and we were looking at just this small charge, it's moving towards the sensor. So it would look like that, and the smaller amplitude because of the smaller charge, larger amplitude because of the larger charge. So what happens if the large charge moves this way and the smaller charge moves that way at the same time? These two things will happen simultaneously. And what ends up happening then is you're going to have the sensor, what it's going to display would be the sum of both of those together, right? So it won't be quite as large of a negative deflection moving away as this larger charge, but you basically you don't see this small charge going through. So when you see this, and you were to try to redraw, hey, what may have happened in this tube, you may think, oh, there was a medium-sized charge that just moved away from the sensor, right? When in reality, what happened was a large charge had moved this way and a small charge had moved the other way. So you just have to be careful in terms of when you see this, it doesn't necessarily mean that there was just only one charge. There are always multiple charges that are contributing to the overall outcome. And the important thing to note is that whenever you see the output of these sensors, it's going to be the net charge movement accounting for all of the charges that had gone through this tube in this dimension at a given moment. And this is a good segue into why we have leads for ECG leads, because each of these tubes is a lead that tracks movement of a charge along a specific axis. Okay, now so we're going to move on to ECG leads, but right before we do that, I just want to review one more time. What we went over in the previous slide was when you have tube with a sensor, let's say it's on this side, and a positive charge, right? Say a large one here, and it moves all the way over here. Then you'll have a signal kind of like this. Now, if you take a similar example again, where let's say I'm going to draw the charge in a different color this time. Here, right? Then what it's going to look like as this charge moves over, let's just say it moved all the way up to here so far. It's going to go all the way over here, but we're stopping it right here at this moment. It's going to kind of go look like that, right? And imagine now, right, the charge is right in the middle here, and there's a sensor right there. And while this is happening, another charge pops up and also starts moving this way at the same time that this is continuing to move and at its destination right over here. So what that would look like if you were to kind of separate the two, it's going to look like this, and at the same time right, it's going to look like that. But in aggregate, what this sensor is going to show is going to be something along the lines of like that. So you may realize if you had a charge and you wanted to characterize its movement in three-dimensional space, then if you were to have a tube going this way, the x direction, another tube going that way, in like the z direction, and then one coming out at us, in the y direction. Remember, each of these also has like the sensor in it that's tracking the movement of this charge. Then you'd be able to, the same way that you would track a point in three-dimensional space in x, z, and y coordinates, you'd be able to do the same thing with the charge. So the problem here is that if you have a charge that isn't moving exactly along the axes of one of these, and it's moving like this one here in a random direction or in a path that's not parallel to one of these axes, then you have to do a bit of calculation in order to figure out what it's doing, right? So wouldn't it be nice if, for example, we had, since this is the X and this is the Y, if we had like an XY plane, right? Characterized by the plane that's made up by the X and Y axes, right? And if we had a bunch of sensors that are along this plane, then we can kind of just look at the one that's appropriate for that specific charge, and we can kind of look at it. Similarly, if we were to look at the XZ plane, right over here, going up, and we were to have a bunch of sensors going out and tubes and sensors going out in all the directions here, then we could just track one of these sensors instead. And that's exactly how our ECGs are organized and why we have so many leads. Okay, now so we're going to actually look at a body here, right? And just like how we talked about in the previous slide here, where we looked at the X and Y and Z directions, and how we can look at the like the XY plane here, right? And the XZ plane here. Oh, it's kind of crooked, but imagine those were in the right direction. Then you can split up this body here just the same exact way. So if we were to kind of show the planes of the body and how we can divide it up, we're able to see the body in cross-sectional areas like this. And what that would actually look like in the cross-sectional areas is kind of like this. And again, just to be clear, the cross-sectional area we're looking at here is the turquoise one, right? And the one we're looking at here is again like the salmon colored one. And we're going to place, so in here, right, the ECG, we're going to just quickly look at all the tubes and sensors that the ECG is recording. It's kind of a lot, but on the XY axis, we got all these red ones here. And in the XZ plane, you see all of these. So how that corresponds to on the body and the cross-sectional areas, to be able to see those a little bit better, kind of like this, where you have your V1, V2, V3, V4, V5, V6. You got your lead 1, lead 2, lead 3, lead AVR, AVL, AVF, and they all correspond to, this is how they look like in this is how they would look kind of like in three-dimensional space. And if you kind of parse it down into two-dimensional space of just looking at the XZ plane first and then the XY plane, this is how the leads are placed and what the sensors are actually recording. So before we continue onwards, I just wanted to quickly go over why the leads are oriented in the way they are. So in the previous slide, you kind of saw things going in which directions and whatnot, and that could be quite confusing. So what we're going to go over is kind of where the leads are and correlate with how that ends up with the vectors that we end up having, the lead directions that we were having. So the placement of the leads that we have are in the right arm. Those are the sticky things basically that we put on our patients for the ECG. Right arm, left arm, with the foot here. And I'm not exactly going to go over the reasoning for this, perhaps maybe just a little bit, in terms of if you have a sensor right here in the right arm, the lead here, it's almost equivalent to actually having it over here, in that any electrical signal that kind of passes either direction to get to here would have to actually pass through here as well to get to here, right, in the body. So same thing, foot, you can have a sensor. It's equivalent to having one right here. Left arm, you can have one right here. And that kind of helps simplify and show a little bit about what we're doing here. So the reason why we've been always talking about these tubes and sensors is that the sensors are these sticky things that we actually have on our bodies. Those are the sensors. And the direction, the tube, or the two things connecting the right arm to the left arm here, like so, is what we call lead 1. The one that's connecting our right arm to our foot here, like this. That should be straight, but in any case, lead 2. And left arm to the foot, that should be lead 3. Right? So if we kind of write this on the side here, that's 1. Down here to here is lead 2. And lastly, here to here, that's lead 3. Now, I won't really go into the reasoning why we're allowed to kind of move these things around a little bit. These are all vectors, but you're able to reorient these and draw it like we saw in the previous drawing. So kind of like this, lead 1. Again, the important thing is that all the angles are the same. Lead 2, so 1, 2, and 3. Now we've gone over 1, 2, 3. We also have AVR, AVL, and AVF. And what these A's mean, it actually means augmented. And that's also another way to indicate that these leads are the ones that are kind of calculated based off of the other leads that we just had, leads 1, 2, and 3. So if you were take the midpoint between lead 2 and draw a vector again towards the left arm, you end up with AVL. It's kind of like this up here, all the way down that way. That one is AVL. This is going to get a little bit crowded in the drawing, but bear with me. The midway point between for lead 3 up to the right arm this way is AVR. Again, so midpoint of lead 3 all the way up to the right arm, that is AVR. And lastly, the midpoint of lead 1 going all the way down to the foot, that is AVF. Down here, that is AVF. Now, if we were to draw all of those onto here, what it would look like is we have AVL, got AVL. We would have going up this way AVR, and downwards here AVF. Now the direction of the arrows here indicate where our sensors would be in our example that we used before, the tubes and sensors. So our vectors here are our tubes, and these yellow dots, as we've been always using, are our sensors. And what you may notice, this is a kind of a technical thing that you don't need to really remember, but just for your understanding, these are all 30 degrees apart. Another 30, another 30. See, now this is the right angle, 90 degrees. So we're able to detect things in 30-degree increments, which is pretty precise, I would say. And so let's try using this. Imagine you have a positive charge here, and it's moving straight across that way. Then what you would see with AVR would be, since this is directly on that line of AVR and it's moving directly away from the sensor, what it would look like is a very strong negative dip like this. And if we look at lead 2 instead, for example, we would see that there's this, it won't exactly capture all of this charge moving that way, because it'll only be able to capture the element that's parallel to lead 1. So maybe the lead 1 component of it is a little bit smaller. So it won't be quite this large of an amplitude, but it'll be and it'll be a positive deflection since it's going toward the sensor. Right? Now, I wished I drew this a little bit more vertically, but kind of like that, I guess, technically. And just to say, if this was 1 unit, maybe this would be technically 30 degrees to 60, 1.7, like 0.7-ish or something along those lines. But in any case, don't worry about it. It'll be a little bit smaller. And say we take lead 3, right? Lead 3 is actually completely perpendicular to the direction of AVR. So there's actually there's no element of the charge that's actually moving along this axis over here. So it would actually not show anything. Now it's nice and all that we have this thing represented right over here on our body, but what we're most interested in is seeing how the electrical signals move through the heart. So as we move forward, we're going to see how this thing would actually be better suited to represent as kind of imagining it somewhere around like here. And remember, these vectors can be moved. So if we need to kind of see how a charge may move from here down to from the SA node down to the AV node, we can conveniently move this whole apparatus right over this charge here to kind of characterize where it goes. Similarly, if you had a charge over here, we can move this whole apparatus to move it right over this charge to kind of see what the ECG show right over here. Now, there were a couple of other leads that we had drawn out before. I'm going to quickly erase all of this. The other leads were the precordial leads. So the other leads that we stick on people are kind of here. This is the sternum, right over here, right lateral to on the right side of the sternum. Left side of the sternum, there's a V1, V2, V3, V4, roughly speaking, V5, V6, and it kind of wraps around the body. And what that does is create, again, a vector space similar to what we had before, except it's a little bit harder to draw, but it's coming from inside the body out towards you, or out towards the surface of the person's body. So it would kind of look like V1, V2, V3, V4, V5, V6. And how that would look on here, it's a little bit harder to draw again, but imagine you have a heart and then the lead is coming, the tube is coming straight out at you, kind of like this. So for V1, this is just to illustrate the concept overall. Not necessarily accurate in terms of the dimensions or anything like that, but you know, it's coming out towards you. These ones going more out toward the side. Kind of like that. It's a terrible drawing, but I hope that kind of clears things up a little bit. So at this point, I would really imagine that looking at all of these things at once is very overwhelming, right? So we're going to just try to focus down into one of the leads. So if you think of your typical heart like we have here, for example, right, where you have your right atrium, left atrium, right ventricle, left ventricle, and the electrical signal tends to kind of start up here, SA node, AV node, and of course it like goes into various places and then comes back here. And then moves down to his Purkinje and then moves up that way. But in general, the direction of all the charges moves down that way, or moves along this axis over here, right? So the one that corresponds to that the most is lead 2 that we have here. So we're going to look at lead 2 and start to look at what a normal ECG looks like on lead 2. Okay, so finally we're going to go over what the normal ECG looks like and just focus on lead 2 instead of looking at all of them. And I'm just going to, here's a little sneak preview of what it's supposed to look like in the end. Okay, but we're going to go over step by step on how we end up with this here. And to illustrate this, I drawn like a rough sketch of a heart here, and it's not necessarily anatomically proportional, but just bear with me in terms of the right atrium being here, left atrium, right ventricle, left ventricle. You got your SA node, AV node, your septum here, as well as the ventricular walls. And here as well, I've drawn in the borders of the valves that separate the left atrium, left ventricle, as well as the right atrium from the right ventricle. And the reason I drew those in is because they are actually electrical insulators. So whenever a electrical signal or charge depolarization happens, and if it hits one of these borders, it'll stop there. It won't go through and propagate and depolarize other areas of the heart, at least in a normal heart. So just wanted to give you that caveat there, or that explanation there. So I think a good way to visualize how this is overall formed is by going through in order how the depolarization process happens. Okay, so we're going to start here. Again, the pacemaker of the heart, the SA node. So now you see here, the charge goes off and the depolarization propagates all throughout the right atrium, right? So what that would look like just for the right atrium is kind of like this. And it stops right here at the AV node, right? And as the right atrium is depolarizing, remember this is not insulation, this is just a border between the right atrium, left atrium. There's no insulation there. So what happens is the signals propagate through and to the left atrium, and then the left atrium starts to depolarize. So if we were just looking at the left atrium, it would actually kind of look like this, a little bit delayed, and starts to depolarize, kind of like that. And of course, once everything's there, the left atrium signals stop here with the insulation, and we are able to depolarize and get to the AV node. So far, the only things that have been active are the right atrium and the left atrium, and the overall signal I'm going to draw and represent here. Lead 2 is kind of oriented this way, right? So the overall signal is kind of downwards, or whatever this lead is able to see is only charges that go directly in this direction, right? So in terms of that, if you were to say the charges are overall going towards the sensor or away, it's going towards it, right? So that's why we have the upward deflection up here, upward deflection up here, and the overall ECG that you'd see from lead 2 would be the addition of both of these. So if you were to put them right on top of each other, like so, you would end up with the overall outcome of kind of like that. Now, this is important to remember because let's say for some reason the right atrium was not really working properly. Then its signal would often get delayed. And what would happen is if the right atrium is working properly, if the right atrium is delayed compared to normal, compared to above here, but the left atrium functions as normally, you'll have these two right on top of each other, right? So it would actually look much more peaked. Or, for example, if instead of the right atrium being a little bit abnormal, the left atrium is abnormal in terms of its conduction, then you'd have the right atrium depolarizing normally where it's supposed to, and then the left atrium would take a little bit longer, And in that case, you may end up with something that looks a bit notched. So here again, normal would kind of look like this. If the right atrium is messed up, then you may end up with something more peaked and narrowed. If there's something wrong with the left atrium, what may happen is it looks kind of notched like this. Now, we're not going to actually go over each of the pathologies that would create all of these things, but just giving you a sneak preview in terms of why it's helpful to understand that there are actually two different contributors to the P wave, as opposed to just thinking of it as a uniform P wave. And it'll help you understand, hey, why does a specific type of abnormality lead to this type of specific change? Okay, so enough about that. So just again, what we went over is this P wave and why that P wave looks the way it does. And now we have to look at this straight segment over here. And what's happening there is, again, let's say the right atrium and the left atrium have finished depolarizing, and now the charge is left right over here. The depolarized portion is waiting at the AV node where there's a little bit of a pause. So that pause there is what you see down here, which is, or up here, where the ECG is reading a flat line. The next part is where the depolarization goes down the septum, down the His-Purkinje bundle. So now you see everything depolarizing. And what's interesting about the heart is actually that the septum doesn't depolarize symmetrically. It actually goes towards the right ventricle. So the overall charge movement is actually kind of like in this direction over here. I guess I should have drawn that in orange. But kind of like in this direction right here. And it may be a little bit hard to see how that overall charge is moving relative to the lead that we have here. So I'm going to just draw it again here. Okay. It's down this way with the sensor down here. And the overall charge is moving in that direction. So when you break down this positive charge's direction down that direction into its the components that are perpendicular to this lead and parallel to this lead, you'll find that the perpendicular element is something along like this, right? And which the sensor is not able to read at all. It doesn't see at all because it's going completely perpendicular to the axis of this tube. And the other element is going, the portion that's parallel to it is actually a small component going out in that direction, which again, you see is going away from the sensor here, right? So then that's why you see the negative deflection down here. And okay, so now that we know that why the little negative deflection happens, we can move on to the next portion, where the fun part where we actually get to depolarize the ventricles. So say the His-Purkinje portion finished depolarizing here, and we see the first part of the ventricle start getting depolarized. So it's down here in this way. So if we were to break down the right ventricle and the left ventricle, just like the same way we did with the right atrium and left atrium before, you will see that the right ventricle has started to depolarize a little bit. So it had been resting before and now is depolarizing. Meanwhile, the left ventricle has not depolarized yet at all. So it's actually just resting at the moment. That is until you get to the second part of depolarization of the rest of the ventricle, where the right ventricle, you can see here, the rest of the right ventricle is all depolarizing. And if you had to guess, maybe the overall movement of the charge is kind of like in this direction. And here in the left ventricle, you have a very large charge moving down this way, smaller charges kind of moving in that direction. But like overall, you'd say maybe the overall charge is moving in that direction. So if you add those two together, you know, the the elements that are pushing the arrow this way cancel out with the arrow pushing that way. So overall, if you add those two things together, like a charge going this way and kind of charge going that way, if you add those two together, it's kind of like a larger charge going down that way, right? Because this component will cancel out of that component, and this component would add on to the other component. So it's a much larger charge going down that way. In any case, the overall charge is probably kind of like this, a very large one going down that way. So how we can illustrate that with the left ventricle, it's probably going to look like a very steep one going up this way, right? And then the right ventricle also makes the rest of the weights up and then down. So in aggregate, what the ECG is going to show is, again, we're going to write them on top of each other. So the right ventricle kind of goes like this and down. Left ventricle also maybe slightly afterwards starts and down. So what it looks like overall is going to be a very sharp one going up and down like this, right? So the overall one is going up and down. But remember, I wrote this at rest before, but as we looked at earlier, when the His-Purkinjes were moving this way, it had a little bit of a negative deflection. So in reality, it's coming from a negative deflection upwards like this. And that's exactly what we're seeing up here, right? We got the negative deflection and then the very large one going up. And then next we got to explain, hey, what is this little blip going downwards here, right? So that one, I'm gonna just take those away there. You got to look at the last portion of the depolarization, where you take away the big portion that just depolarized, and what you're left with is the little bit left on the left ventricle. Because remember, the right ventricle started depolarizing first, and the left ventricle started depolarizing a little bit later, and it's larger, so it takes a little bit longer for it to depolarize all the way. So after the right ventricle has finished depolarizing, you still have a bit of the left ventricle left, and these are actually pointing slightly, like overall, maybe slightly like that direction. So again, if you were to kind of bring this lead and place it right next to here to kind of see what part of the charge's movement is the lead able to actually see, we can go like this, draw another one down here, an example here, a sensor with the overall charge moving almost perpendicular, but slightly actually upwards. So again, you'll break it down into its perpendicular component. The perpendicular component's like this, and then the parallel component to the axis is coming like this. The sensor is not going to be able to see this perpendicular portion, only the portion that's parallel to it. So you have a slight negative deflection actually. So that explains why as the right ventricle at this point now is just chilling, you got your left ventricle that actually has a small blip downwards. And then once it's done doing all of that and depolarized, then it's again chilling just like the right ventricle is. So if we were to add that onto this diagram here, you got the right ventricle continuing to just be there. The left ventricle, after it comes down, it goes down a little further, then back up here. So the overall thing that the ECG shows is a little bit of a blip down here and then back up like this, thus explaining that little blip there. All right, so you may notice that all parts of the heart has depolarized, and what we have ended up with is the right atrium followed by the left atrium depolarizing, the His-Purkinje fibers going, then the right ventricle, followed by the left ventricle, and the last little bit of the left ventricle, and everything is depolarized. And we're kind of missing this bump right there. And where that comes in is when we look at the repolarization. The repolarization of all of the things that had depolarized. So go one by one. The right atrium had depolarized, left atrium, the His-Purkinje. I hope I spelled that correctly. The right ventricle and the left ventricle. So all of these things have depolarized. So we have to make sure all of them are repolarized. So again, I just want to show here the depolarization of the right atrium was kind of like this, right? And actually, so one thing I want to go over first before we go into drawing the repolarization is how the repolarization will look. So repolarization, imagine the sensor here, right? And if you have repolarization happening, when we depolarized, things went from here all the way down to here, right? And then we saw the blip going up. So when we repolarize, we want to bring this charge back to where it was before. And so that would mean things are moving away from it, right? So in terms of, this is as time goes on. So as time goes on, as the charge moves from here down to that way, you'll see it go down this way, correct? So similarly, if we were to track how the right atrium is going to repolarize, we have it depolarize here, and right around here, we're going to see it repolarize. It's actually kind of right smack in the middle of all of this depolarization happening here. So there, that accounts for the right atrium. So let's draw that over here. Maybe like this. Now, if we look at the left atrium, it's like basically the same exact thing. So it depolarized a little bit later than the right atrium, right? And it's also going to repolarize right around the same area. Maybe a little bit down. Basically the same thing. Here, okay, so that accounts for the left atrium. Now, His-Purkinje we'll get back to a little bit later. Now, right ventricle, we're going to look at, this is where we have the right ventricle had not been depolarizing right at all until we hit here, right? And then we had this go up and down basically, right? And then from here, we're going to see the repolarization look that way, which is a little bit strange, right? We had the atria seem to be repolarizing in the same way, right? In the opposite way, as you would expect. But for some reason, the repolarization is the same direction as the depolarization. Now the reasoning for that, you'd have to actually, we'll just look back right at this. So in terms of the right atrium, the way that the depolarization happens is, again, in this direction. And the order of the cells that repolarize also follow in that same direction, right? Makes sense, right? The cells that depolarize earlier are the ones to repolarize first as well. And that's why when you see the overall movement of depolarization move in that direction, you see the positive blip. And when you see the repolarization in the same order, that's the same thing as a negative charge moving in the same direction or a positive charge moving the opposite direction. So that's why you get the negative dip right here. In the case of the ventricles, the order in which the cells repolarize is a little bit different than the order in which the cells depolarize in the ventricles. So in the ventricles, the cells depolarize roughly in the order moving in to out. And what's actually interesting is that the cells in the interior, the subendothelial portion, so basically the cells right at the border of the internal surface of the heart, take longer to depolarize. And even though they start depolarizing first, they actually take longer to depolarize overall compared to the epicardial, subepicardial cells out here. And it's the same story with the repolarization process. The subepithelial ventricular cells actually start repolarizing earlier than the subendothelial ventricular cells. So in terms of the direction in which, the order in which the ventricular cells repolarize, it repolarizes in the order of moving outside inwards. So if for example, the right atrium was almost like having the charge here, a sensor out here, right? And you had a negative charge because it's repolarizing going in the same direction as the depolarization did it, because before it was the positive charge going this way to depolarize, right? Now you're having repolarization, so you have a negative charge moving towards that direction, which is basically a negative deflection. What's happening in the right ventricle is that we're starting the repolarization process actually closer to the sensor, and we're working our repolarization back towards where we started off, right? Before the depolarization happened that way, depolarization start point was here, and then we moved all the way down here to depolarize. Now, when we're repolarizing, we're moving from the outer edge to the inner edge. Again, here, right atrium, we started from the SA node moving all the way down to the AV node. SA node, the order in which we depolarized was from the SA to the AV node. The way we depolarized was from the SA to the AV node. The direction of repolarization is also from the SA node to the AV node. Right ventricle, we depolarized from the subendocardial layer to the subepicardial layer. So subendothelial to subepicardial. And we moved in this direction when we depolarized. But when we're repolarizing, we're actually starting from the subepicardial side towards the subendothelial side. And if we have a negative charge that's moving away from the sensor, it behaves the opposite of what you would believe what the positive charge would do. So it would deflect upwards like this. And that's why we have that up there. And then I won't belabor the point too much for the left ventricle, because the same exact thing happens with the left ventricle. Actually, let's draw in here. What happens here? The repolarization here, and then repolarization happens here. And for the left ventricle, same story. We have what we had here was the depolarization happening slightly after the right ventricle, and then contributing to a little dip underneath, and then we repolarize as well. So what we have here, actually we shouldn't have drawn the depolarization stuff here, sorry. Continuing on here, and then repolarization. All right, and then we said we're gonna hold off on the his Purkinje. So sometimes the his Purkinje also depolarize down here, and we had the little blip here for that, right? And for the his Purkinje, usually the depolarization of that also happens similarly to the ventricles in that it moves upwards. So what you'll usually see here is it's usually buried under the other ventricles repolarizing as well. But sometimes it's actually a little bit more delayed, and you'll see it here, and that'll be called a U wave. So we have our P wave here, Q wave, R, S, T. Or I guess I should have written it up here. That way it's a little bit clearer. P, Q, R, S, T, and sometimes the his Purkinje fibers, as at least we believe that the U wave is made, perhaps from the his Purkinje fibers repolarizing. But here, sometimes you see a U, but sometimes it's buried under here, so you don't see it. One other thing that we didn't account for is the repolarization of the atria and how that fits into the overall picture here. So what can be seen sometimes, which is totally normal, is when you have this P wave, and then you have a little bit of scoop, and then the Q wave moving up to an R, S up, and then another left to the scoop, and then a T wave like this. Now, this scooped portion here, it almost looks like a little scoop up there. That would correspond to the repolarization of the atria. Now, just because oftentimes you may not see those things, and that's totally normal as well. That's the other kind of a little bit annoying part about ECGs, in that there are some normal findings that you don't find in every normal heart. It's just that if you do see a little scoop here and a scoop here in such a way that you feel like you can draw a smooth kind of U shape between those two things. This is, by the way, that smooth U shape, I believe is called a TA wave or something along those lines. You'd be able to, that would be considered normal. But it's perfectly fine and normal if you don't see that scooped portion either. But yeah, okay, that's everything to kind of start off with going through normal ECGs. It's a lot to take in. Maybe you'll need to view this a couple of times to really feel like you feel a little bit more comfortable with seeing all of these things. And it's definitely difficult to see all of these things at once. But having this baseline knowledge is very important and very helpful to learn things in the future, such as how we kind of looked at how the P wave can change morphology. If we see bundle branches in terms of how the conduction is delayed between for the right ventricle or the left ventricle, you may see this QRS kind of splitting apart and seeing the right ventricular upstroke on its own, or the left side on its own, and you may see kind of like an M shape or something along those lines. If you see the U waves or inverted T waves, that also kind of comes into play when you're thinking about the order in which things repolarize or depolarize down here. So this is all very good fundamental knowledge to know, and we'll have another video next about how to kind of go through an ECG at a basic level to start interpretation. Thanks for watching.